Hello everyone, myself Dr. Parth Goswami, and today I am going to teach you a very important topic from bone pathology, that is the osteomyelitis, infection of a bone. Now before we proceed for the further discussion, the normal bony regions and the histology should be clear so that osteomyelitis can be easily understandable. So which are the bone regions? So basically there are three bone regions, that is the epiphysis, metaphysis and diaphysis. This lecture is very important, so stay tuned till the end. So what is the epiphyseal region? So epiphysis means from the base of articular surface to the growth plate region. So here from the base of articular surface to the growth plate area, that is known as the epiphysis. Now above epiphysis we have a metaphysis. So it will extend from a growth plate to the area where the diameter of bone becomes significantly narrow, that is the funnel shape. So this is the area from the growth plate to the area where it becomes funnel shape or it become narrow. So this area is metaphysis. Above metaphysis we have a diaphysis. So that is from the base of metaphysis to the base of opposing metaphysis. So between the two metaphyses the area is known as a diaphysis or shaft. Now in the different region there is a development of different bone tumors, right? And there is a significance in osteomyelitis as well, that we will see later on. Now, which are the bony cells? So basically, there are four bony cells in our body: osteoblast, osteocyte, osteoprogenitor cells, and osteoclast. Osteoblast will form a bone, while the osteoclast will lead to bone resorption. The bone contains the cells as well as the fiber, particularly type 1 collagen and the extracellular matrix. So see, this is the osteoblast that lining the bone, that lining the woven bone, right? Reactive bone. So these are the epithelioid shape. That's why it is the activated osteoblast. The activated osteoblast having eccentrically placed nucleus. So this is the activated osteoblast. Or it can be flattened spindle shape, right? So the bony trabecula is lined by osteoblast here. Then osteoclast. So these are the bone forming cell, osteoblast. While the osteoclast will lead to bone resorption, which can be seen in this particular diagram. It will, do the bone destruction, and it is a multinucleated giant cells. All right. Now, basically, there are two types of bone. If we talk about the general aspect of bone, then two bony types are present: compact and spongy bone. Skeletal system. Our skeletal system is made up of bone, cartilage, and the joints. So bone is a specialized connective tissue which has a structural function, protective function, protect our body, metabolic function, and it's having hematopoietic function as well. Particularly spongy bone contain the bone marrow, which is a source for the blood cell production like that of RBC, WBC, and the platelets. Now, in the center of the bone, we have a central canal, which is made up of, which is consist of blood vessel, nerves, and reticular connective tissue. See, this is the central canal. This is a transverse section of a compact bone. In the center, you can see a canal that is known as a Haversian canal. So that contain, the blood vessels, nerves, and reticular connective tissue. Now, surrounding it, there is a concentric arrangement of lamella. So this is the concentric lamella, circumferential lamella. And in between the circumferential lamella, there is a presence of interstitial lamella. Now, in the lamellae, there is a presence of osteocyte within the lacunae. So in this concentric lamella, this is the lacunae in which osteocytes are present, right? This gutter-shaped depression is seen, that is the lacunae in which the osteocytes are present. The tunicula radiate from the lacuna, that is known as a canaliculi, right? Now the two Haversian canal is connected by a Walkman's canal. So two Haversian canal connected by Walkman's canal. All right, so here you can see lacunae which contain the osteocyte, concentric, then canaliculi, and concentric lamellae arrangement. All right, this is the longitudinal section which shows the connecting Walkman's canal. See, this is the lacunae with canaliculi, right? This is the Haversian canal, and that is connected by Walkman's canal. This is the longitudinal section, so picture is somewhat different. So now let's begin. What is osteomyelitis? If we talk about the definition, then it's the inflammation of bone and marrow. It is secondary to the infection. And the causative agents are various virus, bacteria, parasites, or fungi, among all which the common one is pyogenic and mycobacteria. Pyogenic means bacterial, and mycobacteria that is caused by Mycobacterium tuberculosis. So that two are more common. They are more commonly involved in infecting the bone. So first, pyogenic osteomyelitis means bacterial infection of a bone. The reason for the pyogenic osteomyelitis could be extension from the contiguous site. For example, if you have a cellulitis, then it can spread to the bone. Direct implantation during any surgery or if the aseptic precaution is not taken. Fracture and traumatic injury can puts a patient at risk for development of osteomyelitis. In a diabetic individual due to low immunity, infection can occur. And the most common route is hematogenous, means via blood it will spread to the bones and it can involve the long bone as well. So hematogenous is the most common route. One question is that why osteomyelitis is worrisome in an infant? Why it is more problematic in infant patients that is below 1 year? So in infant, why it is important? Because the epiphyseal infection can spread into the joint, and in a joint it lead to suppurative or septic arthritis. Infection will go into the joint, so it will lead to septic arthritis, and that can lead to articular cartilage destruction. So because of articular cartilage destruction, patient can have a permanent disability, right? So deformity can form because of articular cartilage destruction, and that's why it is worrisome in infant. Which is the most common causative organism for pyogenic osteomyelitis? We know that pyogenic and mycobacterial is common, but which bacteria lead to osteomyelitis commonly? So in a 80 to 90%, the causative agent is Staphylococcus aureus, which is a gram-positive cocci. This bacterial cell wall will bind to the bone matrix component, particularly the collagen, and so it will, adhere to the underlying bone. E. coli, Pseudomonas klebsiella that is frequently isolated in the UTI and IV drug abuser patient. So in a UTI and IV abuser patient, E. coli, Pseudomonas and Klebsiella is a common cause. In a neonates, the common causative organism is Haemophilus influenza and group B streptococcus. In a sickle cell disease, the causative bacteria is Salmonella. In 50% case, however, no specific organism is identified with culture as well. So what is the location of pyogenic osteomyelitis? What is the location? So mostly in a neonate metaphyseal, in a neonate the metaphysis or epiphysis both are involved, because the metaphyseal vessel will penetrate into a growth plate in a neonates. It is not closed, it is penetrate in a growth plate. So in a neonates or infant, epiphysis and metaphysis both are usually involved, but in an adult, epiphysis and subchondral region commonly involved because the growth plate is closed, and the merger of metaphyseal and epiphyseal vessel will provide a route for the bacterial infection, we know that. But here the growth plate is closed, so in an adult the epiphysis is most commonly involved. Now, what is a morphology? Suppose if any of the bone, for example, humerus is affected by pyogenic osteomyelitis, and if you take a biopsy, then what is a morphology? So, as it is an acute infection, acute bacterial infection, the bacteria can be seen, bacterial colony, and there is a lots of neutrophil. A neutrophil will recruit at the site because the neutrophil will do the function of phagocytosis. They will remove the bacteria, they will remove the tissue debris. So, neutrophils are seen at the site of infection, and the bone is necrosed. Coagulative necrosis is seen. The bone is necrosed. It is an irreversible cell injury. So within 48 hours of acute osteomyelitis, bony necrosis occur. And we know that Haversian system, via Haversian system, bacteria and inflammation can have access to reach up to the periosteum. So via Walkman's canal and lamella, they can spread up to the periosteum. And particularly in children, subperiosteal abscess can form because they have a loose attachment of periosteum to the cortex. So subperiosteal abscess will form in children. Now, what is sequestrum? What do you mean by sequestrum? That is commonly encountered in a osteomyelitis. So, in a pyogenic osteomyelitis, the necrosed bone, dead bone, is known as a sequestrum. It's having the rag margin that you can see here. The sequestrum is a fragment of bone. It is a fragmented bone, and that's having the ragged brown to black colored margin. So that is the sequestrum. Now, the infection of osteomyelitis from the bone, it can spread into soft tissue and it can form a soft tissue abscess. Because of extension, soft tissue abscess can form that can do the periosteal rupture. It can spread and it can lead to periosteal rupture. Via Haversian canal infection reach up to the periosteum and periosteal rupture can occur. So it will form a channel to the skin as a draining sinus, right? The channel will form to connect up to the skin. That is known as a draining sinus, and via which the dead bone can be released. The fragment of dead bone can be released via draining sinus. So here you can see the draining sinus is formed. This is the draining sinus. From bone it is connected to the skin. So from this draining sinus, this dead bone can expelled out. Now the second morphological feature is involucrum. So what is involucrum? It's a protective layer. How it is formed? Whenever the acute osteomyelitis is not treated immediately, because of chronic inflammation, it convert into chronic inflammation, and chronic inflammation will lead to release of cytokines. Because we know that ultimately neutrophil is going to be replaced by macrophage, that is a chronic inflammatory cell. It will release various cytokine that will lead to bone resorption, and it can lead to fibrosis as well. That's because of release of cytokines. And under the effect of this cytokine, there could be a reactive bone formation at the periphery. So this new reactive bone formation will form a living cell, or we can say involucrum, around the devitalized infected bone. So it will form a involucrum around the devitalized bone. So that is known as a involucrum. It is a protective bone surrounding the infected one. So here we can see that the new bone formation surrounding the dead bone. This is the draining sinus. So what is the clinical presentation of osteomyelitis? So the infected bone is very painful. Patient will have a throbbing pain because in absence there is a throbbing pain, right? The pain is very severe. Patient will have a fever because of release of cytokines. Patient will have a fever with chills. And as the neutrophil is more, there is a leukocytosis. In a CBC, there is a more number of neutrophils and WBC count. So total WBC count would be more than 11,000. If you do the X-ray of affected part, then lytic focus of bone destruction is seen, that is surrounded by a sclerosis. That is classically suggests toward the osteomyelitis. You can take the material and send it for blood culture before antibiotic treatment, and according to culture sensitivity report you can give the antibiotic. So antibiotic is a mainstay of treatment, and another mainstay of treatment is surgical debridement, surgical drainage. Now, when the acute osteomyelitis convert into chronic osteomyelitis, because every case is not convert into chronic one, the 5 to 25% case will convert into chronic osteomyelitis. So what's the reason? The reason is that improper treatment, inadequate antibiotic therapy, or inadequate surgical debridement. So that can lead to chronic osteomyelitis development. Extensive bony necrosis is very difficult to clear. So in that also chronic osteomyelitis can occur. Weak host defense. If your immunity is low, then there is a chances of conversion into chronic inflammation. And diagnosis if delayed, sometime it happen. The diagnosis is delayed, then it can puts you at a risk for development of chronic osteomyelitis. All right. So that's all about the acute and chronic pyogenic osteomyelitis. Now let's discuss about the specific form of chronic osteomyelitis, that is the mycobacterial bone infection. This is very dangerous because it is more destructive and it is very difficult to control as it is an intracellular organism. It won't easily get cleared by antibiotic. For that, AKT is needed, right? So it is very dangerous and very difficult to control as compared to pyogenic osteomyelitis. and 3% TB affected individual can develop osseous infection. We know that TB occur in lung, liver. It can occur anywhere in our body. So, a bone could be involved in 3%. The symptom is similar. Patient will have a fever, chills, weight loss, and pain. Here, the additional symptom is weight loss. So that will be added. If patient is immunocompetent, then the lesion is solitary because it won't widespread. But if your immunity is low, if you are immunocompromised, then patient can have a disseminated tuberculosis infection in other organ as well. 40% mycobacterial infection can involve the spine. See, very important. 40% can involve the spine, that is known as a port spine. And obviously, as the spine is affected, the intervertebral disc and vertebra can be damaged. And so draining sinus can form there. It can lead to sores, abscess as well. TB arthritis also can be developed as a complication. And one of the notorious complication is amyloidosis. That is the secondary amyloidosis because of release of IL-6 and TNF alpha. That will lead to increased release of serum amyloid associated protein SAA. All right. Disc and vertebral destruction can lead to compression fracture that can culminate into a kyphoscoliosis or neurological deficit. Now, there are two important morphological pattern in osteomyelitis. One is Brody's abscess and another one is Garay's osteomyelitis. So, what is Brody's abscess? It was first described in a medical literature in 1832 by Sir Benjamin Brodie. So he observed that intraosseous abscess in a subacute form is known as a Brody's abscess, where there is a focal collection of pus within the bone and it's having the insidiate onset. So it involves the cortex and it is walled off by reactive bone. So this is the Brody's abscess, right? All right. Second morphology is Garay's osteomyelitis that involves the jaw particularly, and it associated with extensive new bone formation that obscure much of the underlying osseous structure. So tremendous new bone formation is associated in a Garay's osteomyelitis, and that's why it is given the name sclerosing osteomyelitis because there is an extensive new bone formation. So this is the port spine. Vertebrae are affected, and there is a draining sinus formation. So if you do the histopathology, then bone necrosis can be seen, but as it is a tuberculous infection, we can see a granuloma. Granuloma is a specific form of chronic inflammation. You can check the playlist and see the video on chronic inflammation if your concept of granuloma is not clear. So this is the granuloma. Here you can see a caseating necrosis in which we have epithelioid cells, right? So epithelioid cells are present, and we can see that when they combine together they will form a giant cell, particularly Langerhans giant cell, in which the nucleus is arranged in a horseshoe shape. So this is the multinucleated giant cell, right? That is formed because of combination of fusion of epithelioid cells, and this is the AFB stain demonstrating mycobacterial bacilli. In a Port's disease, the infection may break through the intervertebral disc and extend into the muscle. In a port spine, if TB involves the spine, then infection can reach up to the intervertebral disc and it can reach up to the muscle that will form a psoas abscess. So this is your major muscle, psoas major, which can have a abscess formation. That can be seen in this MRI picture as well. All right. Now let's discuss what is skeletal syphilis. Sometimes syphilis, that is a sexually transmitted illness, can lead to osteomyelitis as well. So that's because of spirochetes. And reactive periosteal bone deposition occurs specifically over the tibia. That is known as a Seberstein in skeletal syphilis. In acquired syphilis, bone disease begin early in the tertiary stage, 2 to 5 years after the initial infection. And commonly involved bones are tibia, nose, skull, and extremities. If we talk about the morphology, then in a syphilis, there is a formation of granulation tissue with lots of plasma cell. That is very characteristic. In a syphilis, there is a lots of plasma cell infiltration, and as it is osteomyelitis, necrotic bone is seen. The another important key feature is obliterative and arthritis. Means the vessel is infiltrated by a inflammatory cells, and there could be fibrinoid necrosis of vessel wall. So that is the obliterative and arthritis. And if you want to detect the spirochetes within the lesion, then silver stain or IHC can be done. So that's all about the pyogenic mycobacterial osteomyelitis and skeletal syphilis osteomyelitis. So that's all about the osteomyelitis. Now let's see the lecture and let's see the MCQ. A 9-year-old boy has a pain in the right hip for the 3 weeks. On physical examination, temperature is elevated, swelling with marked tenderness to the palpation in the area of hip, pain, and reduced range of motion. X-ray shows the pelvic and leg showing osteolysis and cortical erosion involving metaphysis with adjacent soft tissue extending into subperiosteal region with abscess formation. See osteomyelitis extending up to the subperiosteum. Which of the following organism likely to produce this finding? So yes, the common causative organism is Staph aureus. So that is the answer. 39-year-old man has experienced back pain since 3 months, chronic cough for 2 years, chronic cough for 2 years. On physical examination, tenderness to palpation over the lumbar vertebra, but no warmth. See, the sign, active sign of inflammation is not present, but tenderness is present over vertebra. X-ray shows the compressed fracture, and CT scan of abdomen showing the abscess involving the psoas muscle. So we know that from vertebra, the vertebra is commonly affected in tuberculous osteomyelitis. So mycobacteria is responsible, and from vertebra it is spreading towards the psoas muscle. So infection of which agent is responsible for this finding? So the answer is tuberculosis, Mycobacterium tuberculosis, which lead to pot spine, and ultimately abscess is a complication. All right, so that's all about the today's lecture of osteomyelitis. Sequestrum means dead bone, and involucrum means surrounding new reactive bone. So thank you very much for listening, and we will be right back with a new video. Till then, take care and bye bye, friends. And if you have any question, then you can ask in the comment section. Thank you very much. Thanks.